Is a third program in our new series or our new initiative for the proactive brain health. And today we're going to be talking about the role of genetics in Parkinson's. We launched the Proactive Brain Health this summer in partnership with C&D Life Sciences, as we understand that there are people that are very interested in knowing what they can do to maintain a healthy brain, but then also for those who might be considered at risk or even prodromal. We want to give them an opportunity to have programs that are directed to their needs, as well as just the general education about brain health. It's just so important for all of us. And I think we're hearing more and more about that. And so the more that we have the ability to detect things earlier, the more we have the desire to make sure that people have access to evidence-based information. And so the Proactive Brain Health Alliance was created to be that vehicle. We do have a webpage, and we'll prop up the link. Well, Kelly already did, to the Proactive Brain Health website. So today's program is being recorded, and you're going to find this recording there. And we will be having additional programs. I will just let you know now that we do have a program at the end of this month. I think it's October 29th. It will be at 5 p.m. Pacific time. For those of you who have maybe been designated as having a prodromal symptom, and or are at risk or preclinical. This is a special program that's not recorded, but gives you an opportunity to ask some questions and connect with those who might be kind of in the space between, which is what we have called this program. And so this is for those who aren't necessarily diagnosed specifically with anything yet, but are interested in being proactive and learning about the things that they can do to make a difference in their health. I am very excited to introduce to you Dr. Padma Mahant. She is actually with us as our clinical partner for the Proactive Brain Health Alliance. And for those of you who may have not met her before, she is a movement disorder specialist with Foothills Neurology in Phoenix, Arizona. And she is also the clinical assistant professor of neurology at the University of Arizona in Phoenix as well. And she also works part-time, I think, at C&D Life Sciences. So she has a lot of expertise, and we're very excited to have her be today's facilitator of this program. So I'm going to pass this over to Dr. Mahant.
Thanks so much, Anissa and PMDA, for this program and this wonderful initiative. I really think that it is filling a gap in terms of what's available as far as resources and information for folks who are either dealing with conditions themselves and are worried about family members and want to provide resources, or for folks who are potentially in that prodromal at-risk preclinical space. So very happy today to have our wonderful speakers today discussing genetics as it relates to Parkinson's specifically. And so I'm going to go ahead and introduce both of them. Ruth Schneider, Dr. Ruth Schneider is here, and she's a movement disorder specialist at the University of Rochester. She's the director of the Huntington's Disease Society of America Center of Excellence. And her research focuses on the development of digital measures of disease, participant-centered remote research designs, the understanding of LRRK2 Parkinson's disease, and you'll learn a lot about LRRK2 in the course of this talk and the course of Dr. Schneider's talk today, as well as the neuropsychiatric manifestations of Parkinson's disease. And then we also have Kelly Minks, MS, CGC, who is a certified genetic counselor, graduated from the University of Rochester with a Bachelor of Science in Molecular Genetics, and then graduated from the University of North Carolina at Greensboro with a Master of Science in Genetic Counseling. She's currently a full-time genetic counselor at the University of Rochester Medical Center in the Department of Neurology. So with that, I will let you take it away, Kelly.
Thank you. Let me just share my screen with you all. Can we see that okay? Perfect. Okay. Well, thank you so much to everyone for inviting me to speak to you today. I'm going to be talking a little bit more about the genetics of Parkinson's disease. So today I'm going to talk about the genetic causes of Parkinson's disease, who's at risk for Parkinson's disease, and also cover some of the reasons people choose to get or not to get genetic testing for Parkinson's disease, including the pros and cons of testing. So let me move my screen here. Sorry about that. So a little background, Parkinson's disease is the second most common neurodegenerative disorder next to Alzheimer's disease. The cumulative lifetime risk up to age 85 years old in the general population approaches 4%. Nearly 90,000 people in the US are diagnosed with Parkinson's disease every year, and more than 10 million people worldwide are living with Parkinson's disease currently. The onset of Parkinson's is most commonly around age 60, but can vary with earlier and later onset. 85%, so the majority of cases are what we call simplex cases, meaning there's only one individual in the family diagnosed with Parkinson's disease, while a smaller percentage, about 15%, are what we call familial, meaning there's more than one individual diagnosed with Parkinson's in the family. And the majority of Parkinson's, so about 90 to 95% of all cases, are thought to be multifactorial, meaning they result from a complex interaction of genetics and environment. And in this case, what we say is the lifetime risk for a first-degree relative, meaning someone who has a sibling or a child with more typical late-onset Parkinson's disease, is estimated to be about twofold greater or have a twofold greater risk than the general population risk. So a good way that I like to think about it is that everyone has a Parkinson's jar. And if you fill the jar to the top with, let's say, marbles, then you develop Parkinson's disease. So everyone is born with some of these yellow marbles in the picture you're seeing, which represent our genetic risk. And these genetic risk marbles are common genetic changes that by themselves don't have much of an effect, but together collectively can increase risk. And some people are born with much more than other people. The blue marbles then represent other factors besides genetics, such as age, environment, and lifestyle. And we all acquire blue marbles in our lifetime. So someone born with more genetic factors or yellow marbles will need less blue marbles to fill up their jar. So in this picture, you can see the top is someone born with more genetic risk, and they need less blue to develop Parkinson's disease than someone on the bottom who's born with less genetic risk and might need more additional risk like environment or lifestyle. Only about 5 to 10% of cases of Parkinson's disease are caused by a mutation in a single gene. And we have genetic testing available only for these single gene causes of Parkinson's disease. So late onset Parkinson's disease or onset over the age of 50 is more likely to be multifactorial, while early onset or onset before the age of 50 and juvenile onset or onset before the age of 20 are more likely to be what we say monogenic or attributed to a single gene. Familial Parkinson's is also more likely to be monogenic than simplex Parkinson's, so having more than one relative in the family is more likely to have a genetic cause. And certain populations, such as the Ashkenazi Jewish population and Northern African Berber individuals, are more likely to have a single gene cause for their Parkinson's. So just as a review of DNA and genes in general, DNA, or our genetic code, can be found in every cell of our body. Genes are sections of DNA made up of chemical letters called nucleotides that the body reads and interprets like instructions. Each gene has a specific function in our body, and we have 2 copies of most genes, one from our mother and one from our father. A change to the coding of a gene, called a pathogenic variant, or also called a mutation, is one that alters the function of the gene and causes or increases risk for disease. We also all have many benign variants or changes in our genes that are unique to our family but do not cause disease. So single gene causes for Parkinson's disease are inherited in different patterns. In this slide, I'm showing autosomal dominant inheritance. So in autosomal dominant inheritance, we need only a mutation in one of the 2 copies that we have of a gene. And we then see a 50% chance of passing on the mutation in the gene to each of our offspring. And we can therefore, in most cases, see multiple affected relatives in more than one generation of a family. Typically, autosomal dominant Parkinson's disease causes later onset or onset over the age of 50. And there are 4 genes associated with autosomal dominant Parkinson's disease. With autosomal recessive inheritance, an individual needs a mutation on both copies of a gene, so one from mom and one from dad. And we usually see an affected individual has parents that are what we call carriers or have just a single mutation in a gene and are therefore unaffected, so don't have Parkinson's disease. Typically, autosomal recessive Parkinson's causes young onset, so under the age of 50, and juvenile onset under the age of 20. In some genes, there's some conversation that it's believed that just being a carrier or having one mutation in a gene may increase your risk for later onset Parkinson's disease. So we can look at risk to develop disease in 2 ways. One is empiric risk using family history of disease, and the other is genetic risk based on whether someone has a gene mutation. So to give an example, if I have a first-degree relative with Parkinson's, such as a parent, my risk is expected to be 2-fold higher than the general population risk, so about 8%. Risk would be expected to be higher if there were additional relatives with Parkinson's on the same side of that family, and risk may be even higher than this if there's a single gene cause for Parkinson's in the family. So should I get tested for Parkinson's disease if I have a family history? There are many reasons that individuals choose to get genetic testing. So genetic testing can give someone a better understanding of their lifetime risk for developing Parkinson's disease. Learning risk may empower individuals to improve their lifestyle and develop healthier habits. Understanding risk may also allow for better financial or care planning for the future. And in some families, this information may allow them to make decisions related to family planning. Lastly, it may allow for the opportunity to be involved in research studies or eventually gene-targeted therapies through a clinical trial. It's important to understand, though, that there's also limitations to genetic testing. So genetic testing may not be able to tell someone definitively that they will or will not develop Parkinson's disease in their lifetime. Many genes, particularly 2 of the more common later onset Parkinson's disease genes, LRRK2 and GABA1, have reduced penetrance. So this means that not everyone who has a mutation in the gene will develop symptoms. There are some individuals who never develop Parkinson's disease despite having a mutation. For example, the most common mutation that we see in LRRK2 is associated with a 25 to 30% lifetime risk of developing Parkinson's in the Ashkenazi Jewish population and a 42% lifetime risk of developing Parkinson's in the Ashkenazi Jewish population. So that means someone would have over 50% chance of not developing Parkinson's disease despite having a mutation, this mutation in the LRRK2 gene. Other mutations in the same gene may have up to 95% lifetime risk of developing Parkinson's disease. We also see reduced penetrance in the gene GABA1. An individual with a GABA1 mutation can have a lifetime risk to develop Parkinson's disease between 7 and 24%, depending on the specific mutation they have. Additionally, there's currently no preventative gene-specific treatment. This means we don't have any medications that can prevent or delay onset of Parkinson's disease, even if we know someone is at higher risk due to a gene mutation. Genetic testing also may not be able to predict when someone will develop Parkinson's disease, so at what specific age, or fully predict the severity or progression of disease. Many individuals may also have psychological stress from learning this information. For example, anxiety, anger, and guilt have all been reported. Additionally, when we do genetic testing, there's also the possibility that we'll identify what we call a variant of uncertain significance, or VUS. This means that we find a change in a gene, but we've not seen that change before. So it's unclear if it's causative of disease or not. We basically don't have enough data to call it a mutation, and we also don't have enough data to call it a benign variant or not disease causing. So this obviously complicates interpretation of genetic test results. So who's offered genetic testing will be somewhat dependent on what center they're being seen at or where they're located, but generally genetic testing for Parkinson's disease is offered to patients who have earlier onset Parkinson's, so younger than age 50, patients with Parkinson's disease themselves, and also a family history, meaning they have relatives with Parkinson's or related disorders, and patients with Parkinson's disease of any age who are Ashkenazi Jewish or North African Berber, which are more likely to carry Parkinson's disease-related gene mutations. Patients with more typical later onset Parkinson's are not routinely being offered genetic testing everywhere, but I do think there is an increased role for this as gene-specific therapy becomes available. And any patient interested should be referred to discuss genetic testing further or referred to a research group who offers genetic testing. That also leaves the question, can patients without Parkinson's disease but with a family history get genetic testing? The answer is yes, but it's a little bit more complicated, and I wanted to walk through a couple scenarios to demonstrate that. So because of some of the limitations of genetic testing that we've discussed, my typical recommendation is that if possible, we test an affected relative with Parkinson's disease first in a family before we offer asymptomatic relatives genetic testing. Of course, there are situations where this isn't possible. So maybe the relative refuses to have genetic testing, or you're not comfortable asking that relative to have genetic testing, or maybe that relative is deceased. But that's our general recommendation if possible. So if we go back to our example of an asymptomatic individual who has a family history of Parkinson's and a parent, we discussed that their empiric risk, so just based on family history alone to develop Parkinson's, is about twofold higher than the general population risk, so 8%. So if that individual chooses to go get genetic testing and their parent has not had genetic testing, we can see 3 different possibilities. One is that they get back a positive result. And a positive result would mean their risk to develop Parkinson's disease may be as low as 6%, so pretty close to risk just based on their family history alone, or as high as 95%. And that would obviously depend on the type of mutation and the specific gene that we see the result. If the result is negative, their risk is actually not reduced or any lower to develop Parkinson's disease. And the reason is that we don't know that their affected parent did not have a Parkinson's disease related gene mutation because they never got genetic testing. So our risk assessment for that individual would still be based on family history and still be about 8%. And then similarly, if an individual had an uncertain result, so if we see a variant of uncertain significance, we would say that their risk was not reduced or increased above the family history risk of 8%. Again, this is because we don't have enough data on this variant to know if it's causative of Parkinson's disease or not. And then next, I wanted to give the same example, but in this example, the first degree relative has had genetic testing. And let's say they have a mutation in the LRRK2 gene. So in this case, we would offer the asymptomatic individual who wants genetic testing, we would offer them what we call targeted testing for the known LRRK2 mutation in their family. So this eliminates the chance of an uncertain result because we wouldn't need to look at anything other than the one mutation in the LRRK gene. And their results would either be positive, which would give them an increased risk, potentially as high as 95%, depending on what mutation in the gene we see, or their results would be negative, which would reduce their risk and put them back at general population risk, because we now know that they don't have the gene mutation associated with Parkinson's disease in their family. So again, more informative in this situation. There are also some potential risks to genetic testing that are important to consider. For example, there is a risk for genetic discrimination. So genetic discrimination is when people are treated differently by an employer or insurance company because they have a gene mutation that increases the risk of developing a disorder. There are both federal and state laws that protect people against certain types of genetic discrimination. In particular, there's a federal law called GINA, or Genetic Information Non-Discrimination Act, that's designed to protect people from discrimination in the areas of employment and health insurance, but does not apply in all cases. So GINA and other laws do not protect against genetic discrimination in the forms of life, disability, or long-term care insurance. For this reason, it's important for individuals considering genetic testing who do not have one of these plans in place and want one, or want to make changes to an existing plan, that they consider the implications of their results and understand that it could affect their ability or cost to get insured. There's also a concern about the potential for privacy or data breach or data sharing with a third-party company if an individual had genetic testing through a direct-to-consumer testing company. So to review what we've discussed today so far, late onset Parkinson's disease is multifactorial and not caused by, or I'm sorry, most typical late onset Parkinson's disease is multifactorial and not caused by a mutation in just one gene. So we don't have genetic testing for this. Genetic testing is available for the most common single gene causes for Parkinson's disease, which account for about 5 to 10% of cases overall. Having a mutation in a Parkinson's disease gene may not mean that you are guaranteed to develop Parkinson's disease in your lifetime. Some genes have reduced penetrance, so it may mean you have an increased risk, but it's not definite that you will develop disease. And it is most informative and if an affected relative has genetic testing first and reduces the chance for an uncertain result. And as you've heard, there's a lot of complexities to genetic testing. So I would recommend that anyone interested in testing or risk assessment for Parkinson's disease, either based on having Parkinson's themselves or having a family history, should meet with a genetic counselor or other genetic specialist to discuss risk and review testing options, including benefits and limitations. And then lastly, I'd just like to point out that the National Society of Genetic Counselors, or NSGC, has a Find a Genetic Counselor directory. So this includes over 3,300 genetic counselors, both in the US and Canada. who are available for either in-person or telemedicine genetic counseling. So this is a good resource for anyone who's interested in speaking with a genetic counselor further about their risk for Parkinson's disease. So I just want to thank you for your time, and I will pass it over to Dr. Schneider.
All right. Thank you so much, Kelly. That was great. And good afternoon, everyone. Thanks for joining today, and I'm excited to share with you my perspective on pre-symptomatic Parkinson's disease genetic testing and talk to you a little bit about our work creating and characterizing a large cohort of genetically at-risk carriers. And it's nice to see some familiar faces on here today as well. So welcome to everyone. So first off, the work I'm going to tell you about today is funded by the NIH, the National Institutes of Health. I do not have any conflicts of interest that are really relevant to the work that I'm going to talk to you about today. So Kelly provided a great introduction to Parkinson's disease. And here I simply just wanted to emphasize the impact of Parkinson's disease on the individual, right? And so classically, we think about it as being a motor disorder where we see bradykinesia or slowness of movement, tremor, stiffness, and postural instability or balance impairment. But, you know, I think anybody who's been touched by Parkinson's disease or has a family member with Parkinson's disease knows that it's really much more than that. So we see cognitive, psychiatric, autonomic, and sleep symptoms, and they're all quite common. And all of these symptoms can be really important contributors to disability, and they can also reduce your health-related quality of life. And we have a lot of available treatments for Parkinson's disease. That's the good news. And many of them are quite effective at targeting, you know, these various symptoms that I'm describing. But we don't have any therapeutics that slow the progression of the disease. And we'll talk in the second half of my brief talk here about why that might be and kind of where work is right now to move that forward. So as Kelly had mentioned, Parkinson's disease is secondary to a really complex interplay between genetics and environmental factors, right? And so Kelly talked a lot about monogenic or single gene causes of Parkinson's disease today. But I also want to just acknowledge that the genetic contribution goes beyond that, right? So there's increasing attention recently to something that's called the polygenic risk score. And what the polygenic risk score, or PRS, is essentially an estimate of an individual's risk for a specific disease, in this case, Parkinson's disease, that's based on like the specific combination of genetic variants that they have, right? And so some of those genetic variants may increase your risk, and some of them may reduce your risk. And the polygenic risk score is basically kind of puts all that information together and comes up with your individual risk for Parkinson's disease. And this score is important in those who have single gene causes of Parkinson's disease and in those who don't have single gene causes of Parkinson's disease. So in other words, you know, if somebody has one of these variants that Kelly talked about, like a LRRK2 variant, your polygenic risk score can influence your ultimate risk, your ultimate chances of developing Parkinson's disease. So this is kind of a long-winded way of saying that knowing your GBA status or your LRRK2 status, for example, doesn't really fully explain the genetic contributors to your risk of Parkinson's disease. Now, on the other side of this screen, we have all the environmental risk factors. And so this would include things like, you know, exposures to pesticides, for example, and different health-related behaviors like diet and exercise. And these also play a critical role in the development of Parkinson's disease. So here, I'm just showing you a non-inclusive list of some of the kind of known and accepted risk markers for Parkinson's disease. So I want to make a few points here. So the first point is that not all of these markers are created equal. So in other words, some of them confer a higher risk of Parkinson's disease than others. And many of these are clearly not modifiable, right? So your sex, your genetic status, whether or not you have a family history of Parkinson's disease, you know, your genetics, that is what it is. You cannot change that component. But if we look at the things on the right-hand side of the screen here, we can start to talk about things that are perhaps or potentially modifiable markers for Parkinson's disease. And so these include things like exposures to pesticides, such as paraquat, exposures to occupational solvents like trichloroethylene or TCE. It also includes non-use of caffeine. So basically folks who do not drink coffee, tea, or other sources of caffeine, and physical activity. And so I think the question in the setting of kind of understanding your risk of Parkinson's disease, if you knew your genetic status, so if you knew that you were at a higher than average risk of Parkinson's disease, would you make any changes? So are there changes in your life that you would want to implement? And when you think about that question, you might say, well, we don't, you know, we need more information. What more can you tell me about that? And you might ask, are there any studies that show that, for example, if I start exercising on a regular basis, will that reduce my risk of Parkinson's disease? Or you might want to know how much picking up a coffee habit and starting to exercise will reduce your risk. And the answer in short is like, no, and I don't know. So we just don't have the answers to these questions yet. We have a number of studies that clearly point to an association between these risk markers and Parkinson's disease, but we don't have these studies kind of moving forward showing how an intervention kind of changes the long-term risk of disease. So I will say that, you know, physical activity, exercise has clear health benefits, and it's certainly what I recommend to folks who, you know, I suspect might be at higher risk for Parkinson's disease. Now, you'll also see on this side of the screen that being a non-smoker is a risk marker for Parkinson's disease. And I'll say simply that this relationship is not well understood, right? We don't understand why this is. And certainly no one is suggesting taking up smoking, which has a trove of negative health effects. So I think this to me is kind of one reason why somebody might want to know their genetic status, is to think about what changes in their life they could make or might potentially make to reduce your risk of developing Parkinson's disease. The other one that I really wanted to touch on today is really more related to research. So both the opportunity to participate in research and to help move Parkinson's disease research forward. So as I mentioned earlier, we don't have any therapeutics that slow or halt the progression of Parkinson's disease, right? And this is not despite a tremendous amount of effort and investment on the part of the research community and individuals with Parkinson's disease. Over the years, there have been many negative studies. And while there are many potential reasons why these studies have been negative, one possibility, and this is just one factor, admittedly, is that we've been trying to intervene too late. So we've been trying to come in at a point at which there has been too much damage done. So to kind of illustrate this, I'm showing here, you know, a figure. And what I'm trying to show is that there's this long period of neurodegeneration, right? There's this long period of brain changes that is happening for years before people develop the characteristic motor symptoms of Parkinson's disease, and for years before a diagnosis of Parkinson's disease is ever made. And so this figure shows kind of one way of thinking about the stages of genetic Parkinson's disease. So in this case, the non-manifest would be somebody who kind of, they know their genetic status, right? So maybe they know they're a GBA1 carrier or a LRRK2 carrier, and that they have a higher risk of Parkinson's disease. Preclinical would be a term we might use to refer to people who have evidence of neurodegeneration, right? So maybe we see that on what we call a dopamine transporter scan, but they don't have any signs, clinical signs or symptoms suggestive of Parkinson's disease. And then prodromal is a term that has been tossed around already this hour, and that really refers to the start of signs and symptoms that are, maybe suggestive of neurodegeneration, but don't really, they're not really sufficient to make a diagnosis of Parkinson's disease, which would be over here on the far right, or manifest Parkinson's disease. So in the studies that we've done to date, we've really focused on kind of this period here. So early on after diagnosis of Parkinson's disease, before somebody has initiated medication treatment. And there's been a lot of discussion in the research community about kind of the need to shift that earlier in the disease course, right? So we want to intervene earlier to delay or even potentially prevent the onset of clinical Parkinson's disease. And I think this is starting to advance beyond talk. So a couple kind of concrete examples of that. So one would be the Parkinson's Progression Markers Initiative, or PPMI. They've announced plans for a Path to Prevention platform trial, where they're going to test various interventions to slow the progression towards Parkinson's disease. And another example would be the Slow Speed trial. This is something that investigators at Radboud University in the Netherlands are conducting. And that's designed to evaluate exercise as a potential way to slow the progression towards Parkinson's disease. And so I'm going to share with you in the remaining minutes a bit about a study that we're doing at the University of Rochester. This study is called LRRK2, or Virtual Assessment of LRRK2 Carriers to Optimize Research in Parkinson's Disease. So in LRRK2, we are following and characterizing a relatively large national cohort of LRRK2 carriers with and without Parkinson's disease. And with this study, really our hope is to address some of the critical questions that we feel really need to be answered before we can move forward with these large-scale Parkinson's disease prevention trials, at least within the specific case of LRRK2. So for example, one thing that Kelly mentioned is that LRRK2 exhibits incomplete penetrance. And so we think about 30% of people who have the particular mutation we're following here, which is LRRK2 G2019S, will go on to develop Parkinson's disease over the course of their life. But we don't really understand, why it is those 30%, right? So we don't know who is most likely to go on develop it and who is most likely not to develop Parkinson's disease. And so one of the questions is, how do we do that? So how do we identify people who are LRRK2 carriers who are most likely to develop Parkinson's disease? Because we don't want to include people in clinical trials who are unlikely to develop Parkinson's disease down the road. And this is, perhaps sounds easy, but I promise you, it's not an easy task. So we know a lot about prodromal idiopathic Parkinson's disease. So for example, we know that things like REM sleep behavior disorder or dream enactment behavior and poor sense of smell are really good early kind of risk markers for Parkinson's disease. But we don't know that much about the earliest stages of LRRK2 Parkinson's disease. What we know suggests that dream enactment behavior and poor sense of smell are probably not that relevant in this particular genetic setting. So one other question we might need to address is, how do we think about progression, right? So how do we, progression in this case towards developing Parkinson's disease might be very subtle. And all the outcome measures that we use in clinical trials are really designed for people who've already been diagnosed with Parkinson's disease. They weren't designed for this kind of early, kind of pre-diagnostic stage. And so to answer these questions, we need big cohorts of carriers who are genetically at risk for Parkinson's disease. So one way we might establish such cohorts and kind of maybe improve the representation of folks in trials is by using what we call a decentralized design. And essentially what this does is it shifts research from the traditional clinic setting into the home. So it enables capture of data kind of directly from participants in the real world environment. And these types of studies can really expand the pool of potential participants. They can broaden geographic participation and ideally lower the burden of participation. And this is how we have designed LRRK2 back in 2018, 2019. So what we've done is we collaborated with 23andMe, the personal genomics company, to identify LRRK2 G2019S carriers. And we are following these folks, all from the University of Rochester, over the course of originally 3 years and now 5 years and counting. So everybody does an annual video visit. And these visits include kind of standard questionnaires, an examination by a clinical investigator, and cognitive testing. And so we collect information on things like mood and sleep, motor symptoms, cognition, autonomic symptoms. We also ask people about those different environmental risk factors that we were talking about earlier. And we have them do a smell test. Now, originally, we planned to continue this study for 3 years. But we recognize the value in longer term follow-up, and we're now at 5 years, and hopefully many more years to come. So we have 277 people who are enrolled in this study. Again, everybody has this particular LRRK2 variant. Some have Parkinson's disease, some don't. And we enrolled these people in a little over a year from 34 states in the District of Columbia. And I think this slide really kind of shows the benefits of this type of research, right? It's much like this webinar that we're doing today. You know, I imagine many of you are located across the US, and this type of technology makes that possible in research too. So out of these 277, 66 had Parkinson's disease at their first visit, and 211 did not. And so just given the focus of the talk today, I'm showing you here a little bit more about the demographics of characteristics of those people who did not have Parkinson's disease. And I'm showing you 3 other kind of traditional brick and mortar cohorts that are out there, just to show that we have kind of similar numbers of people, and that maybe it looks a little bit different, right? So less likely to be Ashkenazi Jewish, less likely to have a family history of Parkinson's disease. I'll also say that about 75% of these participants had not previously participated in any Parkinson's disease research or LRRK2 research, which I think suggests that we are reaching new participants, right? That we're reaching people who might not otherwise participate in research studies. So we've begun to take a look at some of the longitudinal data here, and I don't want you to get too bogged down in the details here. Essentially, what this is showing is that over 2 years, when we look at measures of mood and sleep and motor symptoms, things really don't change. And I think that my take home from this slide is that, again, probably the measures that we're using to assess change in this group are not ideal, and that we need to do things in a little bit of a different way. And so one of the things that we're doing at the University of Rochester is investigating the ability to use digital tools. So things like smartphone applications, wearable sensors, video analytics tools, which may enable objective and frequent assessment out in the real world, and just might be more sensitive. So they might be better able to detect early subtle motor problems and to detect change over time. And so they might be better suited for these prevention trials that are hopefully in the near future. So in Valor PD, we have 2 sub-studies that look at 2 different digital tools. I love my coordinators for being responsible for naming all of these studies. So one is called Rooster PD and the other one is called Opal. I'm just going to tell you a little bit about Rooster PD today. That's the one up on the screen. So Rooster PD uses a framework called PARC, or Parkinson's Analysis with Remote Kinetic Tasks. And in PARC, participants complete a series of kind of standardized tasks, right? So they do finger tapping, they mimic certain facial expressions, and they read certain passages. And this is all recorded. And then we use machine learning models to extract different digital features from the performance of those activities, and then predict whether or not somebody has Parkinson's disease. So thus far, we have about 2/3 of people in Valor PD are participating in this, and many of those have contributed data at more than one time point, right? So we're able to follow them over time with this tool. And so while so far we've really focused on simply distinguishing between folks with Parkinson's disease and those without, what we're starting to look at is whether or not this tool can detect progression over time and maybe give us a sense of who is most likely to develop Parkinson's disease down the road. So this slide is one of my favorites, simply because it was really surprising to me, right? So not only are our participants really willing to participate in digital sub-studies, but they're also very interested in other types of research, right? So this number that was really surprising to me was this 94%. So when we surveyed people at the beginning of the study, 94% of those without Parkinson's disease said they were potentially interested in participating in an interventional trial to prevent or delay the onset of Parkinson's disease, which is really exciting to me. So hopefully much more to come on this study. You know, we had about 90% of people still in the study at year 3, and we just started our year 5 visits down here. And these long-term studies of folks with these relatively rare genetic variants will really help us understand, again, those very early changes. So what are the earliest signs of Parkinson's disease, or things that are going to predict its development in future, again, so that we can intervene and make a difference and hopefully prevent Parkinson's disease one day. So thank you so much for joining and listening to me talk about my research. I'm happy to take any questions, and I will stop sharing there as well.
Thank you so much, Dr. Schneider and Kelly, for your wonderful talks. We have some great questions. To start, though, I thought I'd ask Dr. Schneider, just in terms of this, given that this LRRK2 Valor study seems to be of such significant interest for patients with this mutation, do you foresee similar studies for patients with other genetic mutations on the horizon? Are you working on something similar?
So we have a couple grants under review, and we're hoping to expand the number of individuals participating in Valor PD in the near future. So hopefully more to come on that. I think we need similar studies in GBA, for example, is another one where we really need this information. And then many of you may heard of PPMI, or the Parkinson's Progression Markers Initiative. This is a study that's sponsored by the Michael J. Fox Foundation, and they recruit individuals with Parkinson's disease. They recruit people who are who do not have any Parkinson's disease, and then they also recruit folks who are at risk. So there are opportunities out there to get involved in research for folks who are interested.
Thank you. So more to come, to be continued. Always to be continued with this subject. So one question, thank you for this important program. What should people with genetic mutations know about gene therapy, just in general? Any thoughts from you, Ruth or Kelly?
So I think this is coming, right? So, you know, there more and more in Parkinson's disease, we are recognizing that the pathology, or that the changes in the brain underlying Parkinson's disease, they differ from person to person, right? So it's not the same across the board. And because of that, we need really kind of targeted therapeutics or precision medicine. And one way of targeting our approaches is by focusing on these genetic variants. So there have been and are studies looking at LRRK2 kinase inhibitors, right, that are really relevant for folks who have a LRRK2 variant. There have been other studies that have been targeted towards folks with GBA1 Parkinson's disease associated variants. So these are ongoing. They are not ready for prime time yet. So it's not something that is kind of out in the clinical space right now. But my personal opinion is that I think it's going to be part of our practice in the not too distant future, right? Where you come in, you're diagnosed with Parkinson's disease, you included in that initial evaluation is genetic testing, and that helps to kind of guide what the next step is therapeutically.
And so do you advise patients who know about their genetic status to look at studies if they're interested, like clinicaltrials.gov and any other sources of information on trials that might be ongoing or starting?
Yeah, clinicaltrials.gov is always great. The Parkinson's Study Group has a nice listing of kind of ongoing trials as well. Michael J. Fox Foundation has the Fox Trial Finder, which is another great resource. And then I would say, and I think Kelly would agree, but I won't speak for Kelly, that this is a personal decision, right? To decide whether or not you want to get tested, whether you have Parkinson's disease or not. But for folks that I take care of that know their genetic status, I do kind of encourage at least getting a sense for what's out there as far as clinical trials go.
And just tied in with that, it sounds like you would agree that if more patients have that testing, then that potentially can speed these trials along in terms of providing that base of folks who know their genetic status.
Yeah, I think so. So Parkinson's Foundation, that PD generation study, or PD gene, would be a great example of this, right? They at this time have tested thousands of individuals with Parkinson's disease. And I think they're great because they provide pre-test genetic counseling, they do the testing, and they provide post-test genetic counseling. So, Kelly talked about how important that counseling bit is. And that study really, in my opinion, does it well. And so I think, again, in that case, that knowing your genetic status can really help get you invested, get you involved in clinical trials, and potentially speed the development of new therapeutics.
And in terms of the genetic testing specifically, Kelly, maybe if you could answer this question, is there specific recommendations that you have as far as the direct-to-consumer companies? So Dr. Schneider mentioned, PD generation for patients who've been diagnosed with PD. Is that sort of the first stop for patients who are diagnosed versus at risk? What would you say to folks who are considering it, either if they have Parkinson's already or if they are asymptomatic or at risk?
Yeah, I wouldn't say that I don't recommend direct-to-consumer testing. I would just proceed with caution. So one benefit of direct-to-consumer testing is that it provides increased access to your genetic information. But there are some downsides potentially. So there's no pre-test or post-test counseling to help people, get that personalized interpretation of their results by someone who's qualified to do that. And it's also important to know that a lot of these direct-to-consumer companies are only testing for specific mutations in certain genes. So it's likely not going to be as comprehensive as a genetic test that we would offer in clinic through a genetic testing laboratory. So my recommendation for someone diagnosed with Parkinson's disease would be to talk to your neurologist, talk to the genetic counselor, ask about genetic testing. It should be something that you should be able to discuss with your provider. And if possible, again, someone who's asymptomatic and who's interested in genetic testing, I would find a genetic counselor if you can to talk about more comprehensive risk assessment and potentially comprehensive genetic testing. Hopefully we can get an affected relative tested first in the family just to be more informative. And I also wanted to point out too that PPMI also will offer genetic counseling and testing for free for individuals of Ashkenazi Jewish ancestry who have a first-degree relative with Parkinson's disease. So that is an option as well.
My understanding is that Prevention Genetics, I think that's the group that is working with PD generation, has some genetic counseling. Are you aware of that? So that would be sort of online genetic counseling. Does 23andMe offer that as well, or they don't offer that?
I'm not completely sure. I don't think that it's standard to offer it.
Not standard, yeah.
Yeah,
Got it.
yeah.
So that's the big caution then with the direct to consumer is in terms of that counseling that you might get. And then in terms of if you have an affected relative that has been tested and knows their status, then is it recommended to just get that one mutation? So, Dr. Schneider talked about the polygenic risk score. And so is there more that should be done outside of, just that specific mutation that should be checked, or, is there a panel that should be checked? If you and Dr. Schneider could speak to that.
Yeah, that's a good question. I think that if we have a family where the Parkinson's disease is clearly explained by a gene mutation, then I would recommend only testing for that. We call it single site or, a site-specific testing. So we only look for that mutation. Getting a good family history, though, is important because if there are things in the family that aren't explained, or if there's significant risk for Parkinson's on maybe the opposite side of the family from the individual who had genetic testing, then we might recommend a more comprehensive approach through a panel, which is looking at multiple genes at once.
So I don't, well, I might be wrong, but I'm not sure if there is a direct-to-consumer polygenic risk score, like way to get that for Parkinson's.
Got it.
I don't think we're there yet. And I don't, even clinically, I don't think we're there yet. But in the research setting, I think it is a really useful, it's a useful concept. And I think it helps us understand why, again, some people with one monogenic variant for Parkinson's disease go on to develop it, and some people don't.
And then in terms of young adults that have a first degree relative with a genetic mutation, what would your recommendations or maybe precautions be to someone like that? If there's a patient on here in the audience that has Parkinson's and they're curious about, maybe their children and their young adults, and how would you guide them in terms of the conversation they should have with their, or could have, not should, but could have with their young adult children? Any precautions or recommendations there to consider?
I think a big one would be to just make sure that you're familiar with some of those laws surrounding genetic discrimination. I think a lot of people aren't familiar with those going into genetic testing, and unfortunately it can be a surprise. So I usually tell people to be kind of comfortable with what they have in terms of life insurance, disability, long-term care insurance, maybe hopefully prior to getting genetic testing done, just so that's not something extra that you kind of have to navigate or think about. Should your genetic test be positive, because they can ask you questions about genetic testing when you go sign up for life insurance or
Right.
long-term disability. We just don't have any protections.
Absolutely. And then that question they would have to answer moving forward indefinitely. So another question here, what part does brain donation play in PD genetic research?
I love that question. I think brain donation is very helpful in genetic research, and I'll give kind of one example of that, right? So I was talking about how there are probably different underlying pathologies or brain problems that produce the symptoms of Parkinson's disease. And so thinking again about one genetic variant, the LRRK2 Parkinson's disease, we know that in most cases, we do see these Lewy bodies, which are these clumps of abnormal misfolded protein that are considered like the hallmark of Parkinson's disease. But in a subset, so maybe about a third of people who have LRRK2 Parkinson's disease, we don't see those abnormal clumps of protein. And we don't really understand in those people kind of what is driving the neurodegeneration of Parkinson's disease. And so something like brain donation can really help us kind of link the two things together, right? So we can really understand what is the actual pathology happening in the brain, and how does that relate to the underlying genetics?
Well, with that, I think we are at the top of the hour, so I'm going to toss it back to Anissa. Thanks so much to Kelly and Dr. Schneider for a wonderful program, and join us for the space between that'll be coming up. I'm sure Anissa will talk about that, and we can answer more questions for any that we didn't get to here. Thanks so much. And Anissa, take it away.
Thank you. Thank you so much, Dr. Mahant. Again, Kelly and Ruth, thank you so much for this. Has been very insightful and helpful, I think, to many people. Lots of great questions. So appreciate you taking the time out of your day. I think to everyone for joining us today. And as Dr. Mahant said, if you are someone that falls in sort of that space between and is interested in joining us October 29th, you can register for that through our Proactive Brain Health Alliance website. I know that Kelly just populated it again, so feel free to click onto that, we would love to have you join us to our first one. And that would again be at 5 p.m. on Pacific time. For those of you who are in Eastern time zone, just mark that. And again, thanks everyone for joining us. We're so glad to have this opportunity to start talking about the brain and what all of this means for us. So thanks for the expertise of Kelly and Ruth, and for Dr. Mahant for facilitating today. And I hope all of you have a wonderful day. Thank you.